Hello, this is the NICU Live Network, and we are your hosts. I'm Melinda.
I'm Nat.
And I'm Emma. We are all NICU mothers using our lived experience to partner with health professionals to impact research, advocacy, and clinical practice.
Each week we will bring you something new. It could be a topic highlight, the latest in research, a visit to a NICU, or ways in which you can use your lived experience within the NICU to impact change. We hope you enjoy this episode.
Well, hello and welcome to another episode of the NICU Lived Network. You have all of us. Hi, Nat. Hi, Em.
Yeah.
Nice. Yeah. So in this episode, we're speaking to Professor Denise Harrison. Hello, how are you?
Hi, good morning.
So she's a professor of nursing at the University of Melbourne, and you've been there for a few years now because I remember that you had just returned just before the lockdown. I remember that, and prior to that you were in Canada, so where you worked for 10 years, and you were the inaugural Children's Hospital of Eastern Ontario and University of Ottawa Nursing Research Chair, which is absolutely amazing. And I also know, because I remember this, Denise, you saying that you have been looking after babies as a neonatal nurse, and tell me if I've got this wrong, from about 1986. So a long time looking after our babies, and our nurses are so special to us. So Denise has developed and leads B-Suite to Babies. So it's a really important research that focuses on improving pain management in babies and then implementing evidence-based strategies to help them. It's research that's conducted with many partners, including parents, and I've been honoured myself to be part of it. And I think part of my interest of wanting to be part of this project is because you don't realise how universal it is. Like, pain management applies to every newborn, but especially babies that are born premature or sick. And, you know, they go through so many different routine procedures, whether it's heel pricks, gastro tubes, lines and things. And I don't think when I had my kids that I appreciated at the time how much that they actually went through without pain relief. So it's a really important discussion, and so great to have you. So would you mind sharing a little bit more about you and then the story behind why you became so passionate about this area?
Yeah, sure. Thank you so much, Melinda. So as you said, I've been a neonatal nurse for a long time, and after years of working in the neonatal and pediatric intensive care, I felt I needed to go back to see the normal and the happy, and I knew that would help me to also look after parents, knowing their needs of having a newborn in addition to having a very sick newborn. So I went back to study and I did midwifery, and I loved it, and I really learned a lot about what is normal, what is happy, what is healthy, and how to care for parents. And then I went straight back to the neonatal intensive care, and I really felt that benefited me so much and enabled me to further help parents establish expressing and breastfeeding and further understanding what the role of parents should be. And so after doing one key point during the midwifery rotation in the postnatal unit was my mentor said to me, "We breastfeed all the babies during their heel lances because they don't cry." And I said, okay. I was a midwifery student, even though I'd been a neonatal intensive care and pediatric intensive care nurse for a long time. I had never known that or practiced it or ever seen it practiced. And so I certainly took that knowledge, and she was right. No babies cried. All the babies bled beautifully during their newborn screening. No babies choked. No babies came off the breast. The procedure was quick to perform, and the mothers were happy. It's not something we asked, "Oh, would you like to be here?" It was, "We will be doing the newborn blood test today, so let us know when you're feeding next, and we'll do it during the feed because then the baby doesn't cry." And so that was just part of the practice. And then I went back to the neonatal unit, and this never happened, and even holding babies skin to skin wasn't part of our practice. So that really influenced my ongoing work about how we can work with mothers to breastfeed when the babies are well enough and able to feed, and also mothers and fathers to hold skin to skin during the painful procedures. So that influenced my work. And the other thing was, just one day I got very sad and very angry about our pain management during an IV insertion. And we had to stop the procedure, resuscitate the baby because he got so distressed. He compromised, his heart rate dropped, his oxygen saturations dropped. So we had to stop the procedure, resuscitate him, and then we still had to do the procedure. So from that day on, I thought, I have to do something. We have to do something. We have to learn how to reduce pain during all these painful procedures in our very sick babies. And then I really couldn't stop because I discovered sucrose, very small amounts of sugar water, worked in these very sick babies. But my master's thesis, I only looked at sucrose compared to water in one procedure, and our babies have hundreds of procedures. And so then I moved on to a PhD, which really looked at, does sucrose, if you keep giving it over the course of a long hospitalization in our very sick babies, only tiny drops. We're talking 0.1 of a mil, very tiny drops. And I found that, yes, for our babies that stayed over a month, so I was only looking at our very chronic hospitalized babies, and sucrose continued to work. And then I started looking at going back to breastfeeding and skin to skin. So I thought, yes, I've answered many questions about sucrose and it works and we give it. But what about the family? So my work has continued on with mainly mothers and more recently fathers, because fathers are less visible, but they want to be there. And so I'm now partnering with parent groups, but specifically fathers, as even when I partner with parent groups, fathers aren't as visible, but they want to be there, and they need to be there to support the mothers of the babies too.
That's great to hear that. I know my son was always, when we needed skin to skin with my husband, was always the calmest, breathing was the best, everything was amazing, I think. So I love this, the pain management. Just as a question for you, you know, how integrated are these practices in NICU units now? Because you've obviously done a lot of work across this and a lot of research. You know, what's been the uptake from the units?
Yeah, thank you. It's a great question. So in Canada, I was there really from 2009 to 2011 in Toronto, and then moved to Ottawa for another 9 years. And like all the world, all the developed countries, especially, NICUs use sucrose. So that's very embedded. Parent involvement during painful procedures, not so much. And so a recent study I published with Melinda as a co-investigator and co-author of when we surveyed parents in the parents of sick babies, and only mothers answered that survey, even though it was open to fathers. Mothers had not been involved very often. Some had, and some feedback was great, but most hadn't, and although they wanted to be. So that was their perspective, that we as nurses and midwives didn't help them or didn't facilitate them to be there during heel answers. And so that was the mother's point of view. And then more recently, I thought, well, I need to now know the Australian neonatal nurses and midwives' point of view. And so we did a survey, which we just closed at the end of June, and we've got over 730 nurses and midwives. And so we're only just starting to look at the results. And in healthy babies, our nurses and midwives say that we do facilitate mothers to be there, not fathers. But the neonatal intensive care babies, not so much. And in fact, rarely do we as neonatal nurses support parents to be there. And one interesting question we asked was, do mothers, and then we ask the same question about fathers, ask to be involved? And both nurses caring for sick and healthy babies mainly said very rarely. Wow. So we're not getting the message out there to help parents advocate for their own involvement.
Is that because they don't know that they can be involved?
Yes, I really think that is. They don't know, even parents of healthy babies don't know that they can breastfeed during the procedure. And that's the same during vaccinations. Many parents don't know that they can ask to breastfeed during the vaccinations. And sometimes when they do, again, us as nurses may say, oh, no, we don't want you to. I want you to lay the baby on the bed. So we need to do more to help parents advocate for their role to either breastfeed or hold the baby skin to skin, depending on how healthy the baby is and if they're present, or if the mother's unwell, for the dad to help advocate being there.
I have to confess, when I started when we knew we were going to interview you, I looked a little bit into the pain management stuff. And to be honest, I was kind of a little bit sad because I was like, oh, there was all this stuff I could have done or helped with when, the boys were in NICU and or in pediatrics. And it just, I was just like, oh, I remember there were pockets of things saying, oh, someone mentioned fleetingly sucrose and pain management, but I don't think I had put it all together in my head. But I was like, oh, if I had that time again, there's so much I could have done differently to help.
Yes. And so going forward, it's really trying to get the message out there. As Melinda said, I did a lot of work in Canada, and then I arrived back to Australia and promptly went into lockdown. And Melbourne really had long periods of lockdown. So I weren't able to continue with my research as I had planned, but now I can. And so now it's really getting out there in doing this interview is great, working with father groups as well, and working with our hospital organisations is all part of what we're trying to do to make pain management visible and just part of our normalised care, like it was when I did midwifery. It was simple. We breastfeed all the babies. Okay, it's easy. And we just did. And we didn't even think about our positioning, and we didn't hurt our backs, and we didn't think about babies choking. Babies don't choke. They can protect their airway. And if they can, but even then, those healthy babies, none of them came off the breast. They just kept sucking and didn't cry at all during their heal-out. So it's getting those practices out there into normalised care. And for healthy pregnancies and healthy babies, that's easier, and we can certainly continue to do that. For sick babies, it's really the combination of parents feeling comfortable and us nurses and midwives helping parents to be there. And even if the baby's too sick to actually come out and be held, there's a lot we can do to really contain the babies with our hand, with your parents' hands, to really help contain that baby and still give skin to skin, even though it's not full on the chest. So even for those sick babies, there's things we can do, as well as sucrose.
It's amazing. Yeah, it's really sad. I know when my son was in there, that pain management, he was very sick. So again, that pain, he's got his little scars all over his hands and feet now where they put in the cannulas and all sorts of things. And we had a blue episode where, again, I think that pain management wasn't dealt with particularly efficiently. So it's fabulous, the work that you're doing in that space. With the pain management side of things, I guess it's in your evidence, it's kind of been shown that painful procedures can impact a baby's outcome. Are you able to kind of elaborate more on that and the impacts of that pain management in younger babies?
Yeah, sure. And that's a great question too. So other researchers more that monitor outcomes of premature babies, so not so much the sick surgical babies, but long-term outcomes of babies born preterm, have found that it's the actual number of painful episodes that puts them at the greatest risk of poorer outcomes. And so that's even taking into account how preterm they are and how sick they are. Even within that, it's the number of painful procedures. So it's just a reminder that babies need their drips. They need that monitoring to work out what we're doing. Is that correct? What are their levels? And we need those IVs for their fluids and antibiotics and other medications. So whenever we can, reduce the burden of the number of procedures if we can, and often we can't. So it's making sure that during those necessary procedures, we really involve the parents as much as we can. We use sucrose when we can't get the babies out, skin to skin, and we consistently put in place like sucrose with a dummy helps more if the baby's sucking a dummy, or just containing the babies and with the parents' hands on the baby. So there's things that we can do more consistently rather than thinking as neonatal nurses we're doing the right thing by asking parents to leave. And we think we're doing the right thing, but in fact, you go for a coffee now, you go for a break now, we need to do this procedure. But in fact, that's not what parents want. And we as nurses sometimes think we're doing the best and think that's best for you. But in fact, it's not best for you because you want to be there and stay there, and you want us to help you be there. So part of it's that communication and facilitating parents to stay in the unit when possible.
It really is like kind of that culture. It's almost like a culture shift. Listening to Em and Nat describe their experiences, like there are moments that haunt you, that you look back and you think really sad. I remember when Dylan was being taken to get his eyes checked and I wanted to go, but I was actually stopped. And the reason I was stopped was because they said, oh, you won't want to see that, that it will hurt me, to see him so upset. But looking back now, I should have been there for him, like not, to calm him down, to comfort him. So I know that sits with me. And especially for new parents, we don't know, like we need to be educated. We need to be supported. So I think it's really important and that's the great thing about why we want to do episodes like this, is to help educate parents that they can come in with some knowledge, but also that, within the NICUs, it does become the culture where all through any kind of procedure, there is these 3 options. And they're really simple options, breastfeeding, skin to skin, or sucrose, like 3 really, and as you say, evidence-based strategies that will make an impact that can easily be done.
Yes, exactly. So I also work with our Australian College of Neonatal Nurses and get out there and present widely, but you're still only getting to a small audience, so relatively small audience. So it's working out the best ways to get this knowledge out there, and it's getting there. Like I said, sucrose is very widely used, and that took a few years. And so now it's trying to work on these, the parent involved and parent-led strategies. And also the Be Sweet to Babies videos, the newborn videos, and one shows a mother breastfeeding during a heel lance, and that's obviously a well baby. He had actually been sick but was now recovering, and then holding a very tiny baby skin to skin, but she's not ventilated. So we really need to work on yet another video to show, and obviously that baby was very small, but you can't see any tubes or any monitoring. So there's a risk that neonatal nurses might think, well, it doesn't apply to us because that baby's not sick enough. But our babies are too sick to come out skin to skin. And so, but all the messaging is ask your nurse and your doctor, or your doctor. So it's really getting the message, work with us, work with your neonatal and midwives. But certainly the next project I want to work on is focusing on well, first of all, I have to establish the need, but I think the need is to redo a video with a sick baby being held skin to skin during a heel lance. And it's just making that happen. That's obviously during COVID, I couldn't even get into a hospital, but that is changing now. So I think it's the right time to work on the next steps and really make something that co-produce again with families, that speaks to families and helps both families and neonatal nurses and physicians and lab techs to use this evidence.
And are you sorry, just my question, are you working with the units or the NICU units to kind of get that education piece out to, because I know when I was you're quite conditioned that you know, I remember leaving and being in special care going, I can pick up my child now. So you're very conditioned on what you can do and what you can't. And I think if there's an open environment within the NICUs to actually educate parents that they can be involved if they want to be, then that would help quite significantly too. I guess back to the question, long-winded way of asking, is there an education for NICU units as well?
Yeah, so that's something I haven't managed to really get into yet, into the family involvement in education in the neonatal units, although the Royal Children's Hospital in Melbourne has a program called Cocoon, and it's all about family involvement in care. And I've certainly been involved in that, and I have done a presentation to parents, but it's only one hospital. So it's really, again, getting out there, knowing what's available for parents and other groups. So I've been working with the Australian Breastfeeding Association and Playgroup Australia, and I've been interviewed by them also, and the videos are up there on those sites. So that's trying to get out to that group of families as well. And so it's continually trying to reach people in such a large country when I'm just one person. So
it almost needs to be integrated into FICARE, like family integrated care.
Thinking that, is it not? Yeah, I thought it was. Yeah, okay.
Yeah,
it needs to be like an education part of FICARE, because you are breastfeeding, you are, looking at increasing feeds, you are skin to skin, like that's so integral in terms of, parents taking over as, or, being supported as primary caregivers. Have the discussion about the pain management incorporated into that.
Yes, so again, I've had discussions with the FICARE leaders years ago in Canada, which is one of the places it started, and with the research leaders, and in fact, Fabiana Baccini, who I know she was on the panel where I brought it up, like, where is pain management? And then afterwards I said, I can offer to help, and then I followed up. I can help with this. So it's really getting a voice about, please include pain management in every neurodevelopmental care groups, of which FICARE, really supports that parent involvement in care. And so I do that. Things don't happen immediately, so I'm still trying. So any support from you three with that and your followers would be great too.
Why do you think pain hasn't been a focus if it applies to every single baby? I mean, I'm trying to think any other, part of the hospital or any other ward that a patient would be on. Pain management would always be part of the conversation if they're having treatment, procedures, operations, any kind of, it is a discussion. Why do we not include that with the babies? Like we just so focused.
I guess I can only say our focus is improving. Like, we're getting there. We need to get there faster, but certainly amongst the clinicians, there's a lot more awareness of pain management.
Yeah.
But we still need to involve our families more, and rather than thinking we're doing the right thing, like you said, by asking you to leave, we really need to keep the families involved. So I think we're getting there, but that's the good news. But we just need to continually get the voices out there, the evidence out there. I recently presented up in Newcastle, and both to a midwifery group caring for healthy babies and the neonatal intensive care group. So just bit by bit, it's getting the information out there in ways that parents and staff can reach it.
No, I was just going to say, when you were just saying that, I was like, I just remember visions of me being in the NICU and spending many, many hours staring at walls. And thought, oh, gee, you know, if we had like just, and, you know, because everyone does it, just posters, you know, there are 3 strategies to help with pain management, because I spent hours looking at the same wall again and again, the NICU or the parents' room. Like, you know, it's a very unsophisticated thing. But that, I was like, oh, I could have seen that, in, you know, on a blackboard.
And in this day and age now, like, is this something that we should really be involving as an app? Like pain management in babies, click on the videos, click on the evidence. You know, there's so much more we can do through our e-technology now. Is this something? So our next study, which my postdoctoral fellow, Sophie Jones, is planning, is going back to parents of all groups, so not just parents of sick babies, but parents of all groups. But we will include parents of sick babies in another survey, asking about not just the applicability of the video, but how best can we use this? When should we show it? Should it be made into an app with links to the evidence or consensus statements? So that's something we need to know from families. So we're in that process of just planning it. So we really look forward to your involvement with that in the next few weeks, really, to help us assess the questions. Are they written correctly? Are we asking the right questions in the right way? And so once we pre-test this with groups like you and our SMS for Dads, we can then launch that survey nationwide and work with you to really get it out there to parents.
So I just want to ask, the work that you do, is it also kind of extended to like emergency pediatrics and pediatrics as well? Because when you were talking, I was like, we spent so much time in those other areas as well after NICU, and I was like,
yeah, so certainly for older babies in pediatric units, yes. And these strategies apply, and even more likely to be able to breastfeed. So as the babies get older, skin to skin, we really don't know how that works going on. But even so, if the baby cries, give sucrose, and we certainly say that in our videos. But yes, skin to skin in a toddler probably doesn't help so much, but we don't know. There's no studies. And even in these sick surgical babies, that's my world. That was my world all those years. But most studies exclude those babies. But we certainly know, and so any other, I would love to have more students to really focus on skin to skin in sick surgical babies too. Not do a trial, but really do ongoing observational studies to see how acceptable that is and feasible and how well it works.
So my son was a sick surgical baby as well. So obviously premature, but also had surgery on day 1. So we had that complication of not being able to breastfeed. He had a lot of sucrose in his time, I think. It came back to me. I'd forgotten about it all. But yeah, he had the dummy, the sucrose when we were there. Probably why he loves sugar so much now. But yeah, he was that one. Yeah, he was the same. So we couldn't do the cuddle necessarily, but we knew with the skin to skin, that's where he was literally, he had the best sats, most settled, everything there. So you can see the benefit already, can't you, from doing that? So and he loves to cuddle now, and he's 9. So I think maybe a lot of that skin to skin helps now. So sure. He's the biggest cuddler in the world, I think.
I just wish I was aware of it. Like, I don't know. I don't think I saw it as a cohesive set of strategies. It was just more like, oh, why don't you hold on while we do this? And I was like, okay, but I didn't actually realize the point of it. Like, and then
Yeah, so certainly when I present in my normal, to staff, I always do the rationale and the evidence and the why, like the reason why breastfeeding during a procedure works. But you're right, breastfeeding total, but certainly during a procedure, I talk about that, the movement, the rocking, the heartbeat, and the sucking and the feeding. It all adds to that overall feeling of closeness. And the thing with asking parents to leave all the time is the baby has no advocate. Like the nurses and doctors, we're very gentle. We try our hardest, but we're asking the key person to leave, and we're different every shift, right? So we're not the ones. We come in and out. So we're really taking away the baby's secure person. And so trying to keep the families together. And I know it's hard. I know our parental leave isn't paid enough or long enough. So there's that bigger organization, and we have elderly parents or other children or little toddlers. I know with the original fire care, it's the parents had to commit to being there, 24 hours.
6 to 8 hours. Yeah, it's a long time.
So that's not always possible. But when you're there, let's think about our routine. We don't have to do bloods at 4 a.m. We can actually do them the night before when a parent is there. Yeah. So it's part of it's our strict organisation in hospital. So I've been spending years trying to change that and asking our staff, like, well, this is a routine level, like a routine blood test. It's not going to change. The results aren't going to change in 5 hours. So why can't we do it?
Oh, really? Okay.
Like if it's a antibiotic blood level, well, yes. And if the baby's really terribly sick, but that's not the group we're talking about, right? If they're paralyzed, if they're on so much morphine. But for those babies that we're doing, say, routine TPN testing, which we do, jaundice testing, glucose testing, we've got flexibility.
Yeah. That's great.
Yes, that would be. I'm like, that's that would be challenging to change that culture potentially in a very regimented space.
We keep trying. We just keep pushing, but it's working together, right? It's us nurses helping parents and facilitating parents to advocate, but it's parents also knowing to ask us or to tell us. I will be here during the next blood test when possible, obviously. Please tell me when that is. It's hard because it's a situation where parents are so tired, often so overwhelmed and feel powerless. So it's really trying to turn that around. And that's not just pain. That's the whole NICU care, trying to give the power back to families. They're your babies. They're not ours. Even though even our culture is to say our babies. It's like they're not our babies. Stop saying our babies. But it sounds little, but it actually means a lot.
Yeah.
And again,
Denise, you're such a beautiful warrior for families. It's amazing. So before we wrap up, let's do you mind saying again for families, what are the 3 strategies that parents can do within the NICU to help their baby through their pain?
Yeah, sure. So if the baby's getting well and recovering and able to breastfeed, so breastfeeding when possible, feasible, culturally acceptable during the baby's heel lance or venipuncture. And again, ask your nurse and your doctor who's doing the procedures how you can do that. If that can't happen, skin to skin, and dads can do this too. So just holding the baby skin to skin, naked apart from the baby's nappy against your chest. And while they do the heel lance, or again with the arm out while they do a venipuncture. And if you can't do that, very small volumes of sucrose, which NICUs have, and you can help give that too, just a drop on the tongue a bit before the procedure. And if the baby cries, once they actually prick the heel or put the needle in, another little drop until the procedure's finished. And even then you can help during that by holding the baby, not holding them hard, not holding them down, but just resting your hands quietly and gently on the baby. It can be called facilitated tucking to help keep your baby's arms and legs secure. And they're 3 easy to do things, easy to use. It really helps the nurses and doctors doing the procedures, and just you being there helps you as well, and certainly helps the baby.
Absolutely. Well, thank you so much. I know we're going to pop the links to the videos that you've mentioned in the description. Is there anywhere else people can go to find out more information? So
anyone who just Googles Be Sweet to Babies or Denise Harrison, my profile comes up at the University of Melbourne and elsewhere. I am on Twitter and easy to find, and the videos are also on the Australian Breastfeeding Association and Playgroup Australia sites as well.
Fantastic. Well, thank you so much, Denise. It was lovely to chat, and thank you for sharing the wonderful work that you do. The nurses are absolutely amazing, and, you know, really looking at ways that we can help our babies as they go through so much within the NICUs. It's fantastic.
Yes, thank you so much for inviting me on.
Thanks.
Thank you.
Thank you. It's been great.
That's a wrap on another episode of the NICU Live Network. Thanks for joining us today. To stay connected, please make sure you're following us on social media.
And if you found value in this episode, please share, like, or comment.
We'll see you on the next episode.